billion. Those lower expenditures as of 2019 represent a reduction of 11% in expenditures for Medicare compared to what would have happened under the old law. Now, the magnitude of the reduction continues to increase over time. We estimate by 2030 that the reduction in expenditures would be 20%, in 2050, 32%, and in 2080, 43%. The Act is estimated to reduce the long-range hospital insurance actuarial deficit by 4/5. It is also estimated, as we have heard, to postpone the exhaustion of the HI Trust Fund by 12 years, using the 2010 Trustees Report baseline. Note that the HI savings under the Affordable Care Act cannot directly be used to both offset the cost of the coverage expansions in the Health Reform Act and at the same time to pay for future HI benefits. There are budget and trust fund accounting conventions that result in both these conclusions, and we can discuss this issue further if it would be helpful. As most of you know, I have had some concerns about the one particular provision of the Affordable Care Act, which has to do with reducing the payment updates, the annual payment updates for most categories of Medicare providers other than physicians by the increase in economy-wide productivity. Now, these lower payment updates will provide a strong incentive for hospitals and other providers to be as efficient as possible. But it's doubtful that many providers other than physicians can improve productivity to match economy-wide levels. Possible consequences are that the payment rates for the affected providers will grow at about 1.1% slower than the increase in those providers' input prices. In other words, the input prices they have to pay for wages, office space, energy supplies, things like that. So unless providers can improve their productivity or make efficiency gains otherwise, over time the payment rates will become inadequate to cover input costs. If that happens, and absent legislation to do anything about it, then providers might have to end participation in Medicare, and that leads to possible issues with access to care for Medicare beneficiaries. Now, more likely, Congress would act to override the productivity adjustments if this occurs, as you've had to do many times with the physician payment system under current law. And if so, then that implies that the actual future costs for Medicare would be quite a bit higher than we have projected under current law. To help illustrate the possible understatement of the current law cost projections, the trustees use an illustrative alternative to current law and show a projection based on that.
All right, Mr. Foster, your time has expired, but we'll make your full statement a part of the record. Mr. Blumenauer is recognized for 5 minutes.
Thank you very much, Mr. Chairman. Mr. Foster, good to see you again. I'm interested in exploring 3 points with you. You were here, I thought I saw, for much, if not all, of the previous discussion. You heard one of my colleagues describe with dismay, I believe it was my friend from Pennsylvania, who talked about somebody with a knee brace that under the existing schedule was $686 versus $194 that could be obtained using just going on the internet. Have you examined the current system's trend lines in terms of its sustainability? You're talking about problems under the Affordable. Absent the Affordable Care Act, have you done a projection of what America healthcare looks like in terms of deterioration of quality, of people being shed by plans, other plans being shut down? Do you have a report on that? Have you examined it?
We don't have a formal report. We try to keep up with these various kinds of issues, yes.
Would you say that it's safe to assume if we don't do something, that the trend lines are actually worse in terms of people losing care, costs exploding, inefficiencies in the system?
Without question, something needs to be done because historically, for a variety of reasons, healthcare costs have grown faster than
Right.
people's wages or the economy at large, and that can't be sustainable indefinitely over time.
I take that to say that you acknowledge that it's actually worse if we don't do something, that people are going to lose care, the quality's going to go down, the budget's going to be broken if we don't do something.
Oh, I don't know about worse or better. That's something I'd have to think about, but
I would appreciate it if you would, because you've thought about it here. You've made the decision that actuarially and your assumptions, your hunches, being around here a long time, that you think some of this isn't going to happen. I would appreciate that you would add your intellect to what the consequences are for the current system absent doing something, whether it's going to be better or worse. My second point, I wonder if you've had a chance to look at the Republican roadmap that my good friend and colleague Paul Ryan has advanced that actually posits greater reductions in Medicare spending over time. And I would ask if you think that is greater or less likely that Congress would stand by and allow greater reductions. If you think there are problems under the existing act, would they be greater or lesser reductions under my friend Paul Ryan's approach?
my office looked at Mr. Ryan's plan several years ago when he first developed it. We discussed with him at the time, and it continues to be the case, that if you have a voucher program for Medicare and Medicaid and the voucher payments increase at a slower rate than healthcare costs are increasing, then over time people cannot buy as comprehensive an insurance coverage as they start out. And at some point that could become quite an issue. So there are risks to either approach. They're different in nature, but they both exist.
I don't want to catch you unawares, but I would respectfully request that you think about that, maybe look at them, and if you have an opinion about which is the greater risk of Congress caving, those draconian cuts, or the things that are imposed under the Affordable Care Act at some point. I would like to turn to the Medicare Advantage, because this is one of the areas that you think there's instability. You were here when Dr. Berwick testified that the current Medicare Advantage enrollment increased 6% to more than 12 million beneficiaries. You heard that on average, beneficiaries have seen a 6% reduction in their premiums. And you heard, most important, there are a 5% increase in the people who are investing in the better, higher quality programs. I mean, there's some that give health club memberships but aren't very good programs. And we don't want to subsidize ones that aren't doing a very good job. I note in my community, you get about $586 on average, and we have the highest percentage of Medicare Advantage in the country. In Louisiana, there's one that's over $1,300 a month.
The gentleman's time has expired.
I'm sorry.
Ms. Black is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Foster, for being here. As a part of the Democrats' health care law, employers who provide retiree drug coverage can no longer deduct that subsidy, the so-called RDS. And we've seen companies take huge write-offs as a result of this tax increase. And an example of that has already been talked about in the last session was AT&T with $1 billion and Deere & Company with $150 million. And these are big numbers, and it means that there's less money will be available for investment and creating jobs. But my question relates to the impact on seniors. The President reiterated on Sunday, and I quote, "If you have health care that you like, you keep it," end quote. In your opinion, does the Democrats' health care law provide further incentive for these companies to drop the retiree drug coverage plan, resulting in seniors losing their coverage?
Yes to the first part, probably not to the second part. In other words, without the tax deductibility, that changes the financial balance. So we expect that many employers will drop their retiree drug coverage because of these changes. We also expect that most of them, not all, most of them will help get their retirees into regular Part D prescription drug plans.
As a follow-up to that, how is this going to affect the regular Part D moving forward?
It won't make a lot of difference. Instead of Medicare paying a federal subsidy for these same people within their retiree plans, we'll pay a federal subsidy for them within a Part D plan.
I see.
It will slightly decrease the premiums because these tend to be lower cost people. They've had full employment histories. So it will help bring down the overall cost within the Part D plan world, but not by very much.
I want to go in another direction that really hasn't been mentioned much here, but there was some talk in the last session about how these senior groups have promoted the recent reform, and AARP was certainly a part of that. However, as a part of the new law, insurance companies are required to spend 80 to 85% of the premium on government-approved spending services, and this is called that medical loss ratio. However, Medigap policies that seniors purchase to supplement traditional Medicare are only required to meet a medical loss ratio of 65%. And AARP and United are a part of this. And while I'm not in support of government mandating on how private industry operates, do you think that the MRL policy should be applied equitably across the line?
Well, I'll confess that's not an issue I've thought much about, but and I don't get into policy issues, but you could probably make a good case that if it makes sense in general, then it would make sense for the broader spectrum, including Medigap policies.
Well, I would think that most people would agree that if we're going to do something, we should do it equally, I'll say, and that if we have one particularly company that is advocating for a policy and then gets the break to be less, that does not seem to be very fair.
There's one other difference that I'd mention, which is when you think of a normal health insurance policy, like a private insurance policy that covers the whole gamut of health care services, there's sort of a lot of money to work with. If you think about a Medigap policy, which wraps around Medicare, it's a much lower dollar value policy. So to the extent that you have given administrative costs, they're going to tend to represent a greater share for a small dollar policy. So you might not be able to do 80 or 85%. But on the other hand, you could certainly specify a loss ratio standard that is perhaps somewhat higher than the existing one.
Thank you. I yield back my time, Mr. Chairman.
Thank you. Mr. Pasquarello is recognized.
Thank you, Mr. Chairman. Mr. Foster, it's good to see you again. Is it on? Thank you, Mr. Chairman. At many town hall meetings that I've attended, Mr. Foster, it's been my goal to dispel some of the myths that we've heard discussed today and other days. And seniors have been grateful as they've begun benefiting from health care reform. For example, in getting a $250 check, which doesn't seem much to you or me, but means a lot to a lot of seniors, to help them pay for prescription drugs under Medicare. I don't have any trick questions about that, but I just want to lay the facts out.
I appreciate that.
I'm sorry?
I appreciate that.
Well, I'm not finished yet, though. We also learned something this morning. It seems like both sides are convinced that we finally laid it out chapter verse. And would you confirm this, that there are no cuts in guaranteed benefits under the Medicare program? Would you verify that? Except, we're not talking about the private plans. We're not talking about doing away with gym privileges. We are talking about substance, and you know what I'm talking about.
Yes, sir. There are no cuts in what's referred to as guaranteed benefits. In other words, the standard Medicare benefit package.
Thank you.
In fact, that's been expanded.
Thank you very much. Your conciseness, I hope people will choose to go back and read the bill, which we were accused of not doing. But that's a fact of life. Now, I want to ask you something which I would ask you to be as precise as you can be. I want to talk a little bit about how health care reform creates what I would consider to be positive incentives for providers to focus on the quality of their care, thereby benefiting seniors. I understand that your office did not score innovative ideas such as hospital value-based purchasing or the Independence at Home demonstration program as part of your analysis. In fact, I look at the sheet from the estimated Medicare costs and Section 303, the expansion of the physician feedback program, Sections 3006, 3007, value-based purchasing, which I know you believe in, but you did not score. I'm not criticizing, I'm going to ask a question. CMS Innovation Centers, the Medicare Shared Savings Program, National Pilot Program on payment bundling. Seen a lot written about that in the last 3-4 years. Hospital readmissions reductions program. Let me ask you this question. Do you think that, don't any of these specific areas, I can name 5 more, have any potential for savings? And why specifically were they not scored? Because you did score some other things.
Sure. In a number of cases, we actually did estimate savings. For example, for the lower payments for readmissions, unnecessary readmissions, the hospital-acquired conditions. What it really depends on, sir, is when you have enough information about how the proposal will actually work. On some of these, for example, at the time of enactment, the Medicare Shared Savings Program was not adequately specified for us to be able to estimate what the impact would be.
So it isn't a question that you thought that they would not work. It was a question, and correct me, it was a question of having enough information to say that they definitely would work. Am I putting words in your mouth?
Only slightly. It's a question of having enough information to determine that they work well, they don't work so well, as the case may be.
So you're not questioning whether these things would work?
I'm saying we don't always have an opportunity or enough information to try and figure that out.
Well, let's take the 5 things that I've mentioned. You would think, from what I've read and what I've looked into to my amateur abilities, that we could possibly save a heck of a lot of money if these things work as well as they're expected to work.
There is the potential in almost all of these, but if I may give you one example.
Sure.
The Medicare Shared Savings Program, as you know, the regulation is due out within another couple weeks. And we've been working closely with the folks on that. The original design of the regulation, we estimated would actually increase costs. The design was modified somewhat to lower the cost. And the current version now achieves some degree of savings overall.
All right. Thank
This
you.
is quite a bit of money we're talking about here, though.
The gentleman's
Thank
time
you.
has expired. Thank you. Mr. Crowley is recognized.
It's unusual 2 for in a row here. But thank you, Mr. Chairman.
playing catch
wanna-
up.
Sorry?
We're playing catch-up.
Yeah, good man. I want just to follow up on the line of questioning of Ms. Black as it pertains to corporate tax advantage that she mentions will be phased out in 2013. What is in effect a case of, in my opinion, I think many, a double dipping. Now, I would hope that my Republican colleagues aren't defending double dipping, but that's what it sounded like to me. The loophole that will expire in 2013 pertains to a law that allows businesses to deduct the value of that subsidy twice. they can exclude the 28% from their income and at the same time deduct 28% from their income for tax purposes. If that's not double dipping, I don't know what is. The health care reform legislation closes that loophole by allowing businesses to deduct this money once rather than getting a double deduction on taxpayer dollars. These businesses will still get a generous subsidy to help them cover retiree prescription drug costs, and they still get to exclude that benefit from their income. They just don't get to do it twice and double the deduction on the backs of taxpayer dollars. But Mr. Foster, what I want to do is follow up on the questioning of my colleague from New Jersey just a bit more. One of the Affordable Care Act's greatest tangible benefits was the assistance it provided to our seniors with high prescription drug costs, particularly those who got caught in what is known as the Medicare Part D donut hole or coverage gap. The law gave every senior who was hit in that coverage gap in 2010 a check for $250. Is that correct?
Yes, the ones who made it to the coverage gap.
That's equivalent of 7,300 seniors in my district alone and over 3 million seniors nationwide. These are checks that seniors have already received that they are already using to help them to pay for the high cost of prescription drugs. Is it true that the Republicans' efforts to repeal the Affordable Health Care Act, which each of my colleagues on the other side of the aisle voted for, as if it had not been enacted, I quote, as if it had not been enacted, would force seniors to return that $250 check that they received to help them with the cost of prescription drugs? Would that be the case?
If the legislation were repealed entirely and retroactively, including provisions that have already taken effect, then yes, in theory, you would have to pay back those rebate checks.
Let me ask you this question. If that were the case, if they had to pay back those checks, and that would amount to over $650 million that has been paid out, is it possible that when seniors are forced to return those $250 checks that they got, that they would have to pay interest on those $250 checks as well? It's $650 million. I would assume that had that stayed in the Treasury, that it would have accumulated some interest. Would they have to pay the interest back on those checks as well? Yep.
I'm sorry, I'm not aware of any situation where if there's a benefit overpayment and a recovery, that interest is involved.
But it's quite possible they may have to pay interest on that.
I've not seen it before. It's not to say.
So then it would be a loss to the Treasury, the interest that would have otherwise been garnered had it remained where it was.
In effect.
Quite possible, right, yeah, there would be, thank you. My Republican colleagues have said that they want to completely take away all funding for the Affordable Care Act, and they have made it clear that they will use the continuing resolution to cut off any funds for the implementation of this law. Would this mean that the remaining seniors who hit the prescription drug coverage gap towards the end of 2010, just like their neighbors, and are waiting desperately for their help, will now be denied the check that is rightfully theirs if funding for this law were to be cut off?
Again, if it's repealed in its entirety and retroactively.
Thank you. Mr. Forster, the Department of Health and Human Services estimated that under the Affordable Care Act, Medicare beneficiaries, seniors who have hit the prescription drug coverage gap will each save $526 this year alone as a result of further closing the coverage gap. By 2020, when the gap is fully closed, each beneficiary will save $1,540. This means a total savings of $8.8 billion in savings to a projected 5.7 million beneficiaries. If the Affordable Care Act were repealed, Medicare beneficiaries would effectively see an $8.8 billion cut just from this particular provision being repealed. Is that true?
I'd have to look up the figures, but those are in the right ballpark.
I thank you, and I thank you for your honesty and your candor, and I thank the chairman.
Thank you. Mr. Foster, would you agree that health care spending and rising health care costs are the most significant drag on our nation's fiscal health?
Oh, I don't know about that. They certainly represent.
Or a significant drag on our nation's fiscal health?
Well, certainly, yes.
Okay. And one of the claims that is often made is that this health care law will, quote, bend the curve. of healthcare spending. In your expert analysis, would you say that their law increases or decreases national health expenditures?
We have estimated that overall national health expenditures would increase under the Health Reform Act.
So a significant drag on our economy is actually made worse under this law. My second question is, the Nonpartisan Congressional Budget Office has made clear that the Medicare, quote, savings as a result of the health care law can't be counted twice. First, to shore up the solvency of the Medicare program, and then also pay for a new health care entitlement. Your office's April 22nd, 2010 report on the effects of the law on the Medicare Trust Fund pointed out, and I'm quoting, "In practice, the improved Part A financing cannot be simultaneously be used to finance other federal outlays, such as the coverage expansions under the PPACA, and to extend the trust fund, despite the appearance of this result from their respective accounting conventions." Can you sort of settle for this committee with a yes or no answer? If the funds that are designated to finance a new entitlement under the health care reform law, can they be simultaneously used to make the Medicare Trust Fund more solvent?
Not directly, no.
So what is the implication of that truth about the solvency of the Medicare program and on the alleged deficit reduction in the Democrats' health care law?
Well, what I'd like to do would be to explain it as follows. Clearly, there are very large Medicare savings under the Health Reform Act. Those savings, the actual cash that shows up in higher payments, higher taxes, whatever, that is loaned to the rest of government. The Medicare trust funds get treasury bonds, IOUs. The money is immediately spent, whether it's for the purpose of the offsetting the cost of the coverage expansions or building roads or whatever, it's spent.
Right.
In a few years, when we need the money, we can cash in those treasury bonds, and it has to be repaid with interest. But the original money we're talking about, if it was $100 in higher taxes, the $100 is spent, it's gone. We now need the $100, we'll get it back, but Treasury will have to come up with a new $100 to pay it back for us. So to spend $100 for the ACA and $100 for Medicare takes $200. And the original $100 can only be used once.
So the costs of the bill are understated.
I think that's a different issue.
All right. I wanted to just touch on something else. The Health and Human Services, HHS, spent about $20 million to convince seniors that the health care law was good for Medicare. And one of the first attempts to do that was this color mailing. It was glossy, that went out to seniors to inform them of a number of new government programs, even though they were ineligible for many of those programs. Was your office asked to review the Medicare mailer or that went to seniors, or to review the scripts that appeared in the media that were aimed at seniors? Did your office review those?
No, we were not asked, and we did not look at them.
There were a couple of comments on two statements that were included in the Medicare. I'd like you to comment on two statements included in the Medicare mailer, and to just give your comments on whether those were accurate, inaccurate, or misleading. One was, it keeps Medicare strong and solvent. Is that an inaccurate or misleading, given that the Medicare cuts are unsustainable and that the, quote, savings are double counted, as you mentioned earlier in your testimony? Double counted as both trying to extend the Medicare solvency and also pay for a new entitlement?
Technically, and in an important way, the savings for Medicare under the Affordable Care Act do extend solvency. Now, we lend the money out, we get it back, we can continue paying benefits longer than before. Now, there's the appearance and a good bit of reality of the double counting, so that's an issue. But technically, it does help in that regard.
The quote that Medicare benefits won't change, whether you get them through original Medicare or Medicare Advantage plan, is that an accurate statement?
I'll be quite honest, I've been troubled with that statement. We had the question earlier about the guaranteed benefits. It's true enough that the, quote, guaranteed benefits, which are the original fee-for-service package, nobody's reducing that. That actually expands a little bit. It's also true that for Medicare Advantage enrollees, their extra benefits, their lower cost sharing, their lower premiums, will be reduced. under the Affordable Care Act.
And when you reviewed the, whether this legislation, quote, bent the cost curve or not, did it include any analysis of the physician payment formula or any extension of that, or, quote, doctor fix, as it's often called here?
No, not directly. Other than the original Ways and Means Committee bill, the legislation did not have a doctor fix in it.
So that's a fairly significant cost to Medicare that has not been accounted for or included in this legislation.
Yes, it's been treated as a separate issue.
So the, in response to my question about increasing or decreasing healthcare spending, even your analysis would would be pretty significantly understated if this were included.
The cost of a permanent fix for the SGR system over 10 years is about $300 billion. That provision was not in the Affordable Care Act. It's a continuing issue, as you know, but that is roughly the cost.
So that would mean healthcare expenditures would increase by that additional amount over that period.
That's correct.
All right, thank you. Mr. Levin may inquire.
Mr. Foster, welcome, and I think this may give us an opportunity for further reference to the facts. You answered the question of the chairman about benefits. The guaranteed benefits are different than the extra benefits under the Advantage programs. Isn't that true?
Yes, sir, that's correct.
Okay. See, there tends to be always confusion or an attempt to confuse. For example, there's reference, as was done earlier today, cuts in the payments. So let me just quickly review your testimony because I think it's important to get to the facts. On page 3, you say that it's estimated that the number of uninsured persons in the U.S., it would reduce it by 34 million. You don't challenge that, do you?
No, sir, that's our best estimate.
Good. You then, going to page 5, say that expenditures are expected to increase by about $200 billion due to the substantial expansions of coverage under the Affordable Care Act. So if 34 more million are insured, it's likely the costs will go up overall, no?
Yes, that's correct.
Right, so let me just go on page 5, and you talk about the Medicare savings. There have been references here to cuts in Medicare payments. Isn't it more accurate to say that these cuts will come from a reduction in the increase in Medicare payments?
There's a lot of each. Certainly for the productivity adjustments that I mentioned, that's a slower growth in payment updates.
Okay.
If you think of the disproportionate share hospital payments, that's a flat-out reduction in the level. So there are examples of each.
Okay, so to simply talk about cuts, as has been done in many of the statements, including advertisements, whatever, about the over $500 billion, $500 billion in cuts in Medicare payments, much of that is in the reduction of the increase in Medicare payments. Isn't that correct?
Yes, a significant part of it is in that form.
Also, bending the curve. When we talk about bending the curve, we're talking about bending the curve in terms of the rate of increase and bending the curve in the rate of payments to providers, are we not?
Bending the curve generally refers to slowing the overall rate of healthcare cost growth, not necessarily how it might be done.
But it also, when we talk about bending the curve, there's an effort, it indicates an effort to try to bring down the cost of the payments to those who provide care, no?
Well, clearly that is one way that the Affordable Care Act works to try to slow the growth of healthcare cost.
And it really does try to do that, does it not?
Yes, sir, primarily through the Medicare productivity adjustments.
Okay, now, I just want to finish by referring to that, because there's a statement to take, there's an indication, an effort often to take somewhat qualified statements of yours and to indicate that essentially it's sure to happen. And I think that we need to look at your testimony, because you say on page 8, although this policy could be monitored over time to avoid such an outcome, changes would likely result in smaller actual savings than described for these provisions. Essentially, what you're doing is projecting. For example, you did this to the Advantage programs, and so far this year, it's turned out your projections are wrong, right?
I'd stop short of calling them wrong, and without appearing to be defensive. The real issue is 2011 is not much affected by the Affordable Care Act. 2012 through 2017, there will be big effects. There are factors unrelated to our estimate of the Affordable Care Act that have resulted in 2011 Medicare Advantage enrollment increasing by more than we thought it would.
All right, thank you. Mr. Herger is recognized.
Thank you, Mr. Chairman. Mr. Foster, the President and his administration have repeatedly said that we must pass their health care overhaul because controlling health care costs would help the economy. On June 2nd, 2009, the Council of Economic Advisors said, quote, "We estimate that slowing the annual growth rate of health care costs by 1.5 percentage points would increase real gross domestic product relative to the no reform baseline by over 2% in 2020, close quote. The President's economic advisors also stated that slowing cost growth would lower the unemployment rate. The President's economists also argue that slowing the growth rate of health care costs raises standards of living by freeing up resources that can be used to produce other desired goods and services, close quote. Based on your analysis, will the Democrats' health care law slow the rate of health care costs so we can get these outcomes like more growth and more jobs?
Overall, the Affordable Care Act increases total health spending and increases federal spending on health care. There are some factors in there that would help slow the growth rate farther out in the projection period. One of the largest of those factors is the one that I've questioned the long-range viability of.
And Mr. Miller, in an auxiliary, Mr. Foster, in an auxiliary report to the Medicare Trustees 2010 report, CMS actuaries predicted that under the new health care law, by 2019, Medicare payment rates will be lower than current Medicaid rates. In your recent testimony before the House Budget Committee, you confirmed that the best case scenario under current law is that Medicare rates will be equal to Medicaid rates in 10 years. What impact would these rates have on beneficiaries' access to care?
If Medicare payment rates become lower than the current level for Medicaid, which in fact would happen over time under the Affordable Care Act, then it raises questions about the ability of beneficiaries to have access to care. Within the Medicaid program, as I'm sure you know, there are a number of studies that suggest access has been something of a problem and getting worse. So you basically have to provide a reasonable payment rate for physicians and hospitals and anybody else in order to enable them to provide health care services to Medicare beneficiaries or anybody else.
That would be a major problem, wouldn't it? I mean, we're already seeing a problem of doctors taking new patients, and to think that that would be more dramatically affected, does that concern you?
It concerns me primarily because I think this would tend to happen over time, and whether it's 10 years or 20 years or somewhat longer is a little hard to say, but I believe it would happen. I believe you folks, Congress at large, would have to respond to it because it makes no sense to have a Medicare program where Medicare beneficiaries cannot get access to care. So I believe you would have to override the provisions, and that would result in a higher cost than we now project under current law. That's my primary concern.
Thank you, Mr. Foster.
All right, Mr. Rangel is recognized.
Thank you, Mr. Chairman, and welcome back, Mr. Foster. I would want you to clarify your status as an independent analysis. I gather it's not your job to evaluate whether or not you think this program is good, bad, whether it's going to work or whether it's not going to work. But one thing you did say is that it would increase medical costs, and I wonder whether your job title and responsibility would say that while it would initially increase the amount of money the federal government is paying, that in terms of prevention and the fact that everyone will have access to health care, does it come within your protocol to determine whether or not in the long run medical costs would be reduced as a national expenditure?
The which part of medical costs, sir?
Overall medical costs. In other words, many of we lay people believe that if indeed people who now have no coverage, that we're paying for their very high emergency costs, and we're paying for it with the federal government, and we're paying for it with increased premiums. Actually, the federal government initially would be paying more money for health care, but would you evaluate what is preventing from happening that would also cost money? Is that a part of your responsibility?
Yes, sir. You correctly stated that we don't evaluate whether a proposed policy is a good idea or a bad idea. Our role is to help policymakers understand the technical aspects. Will something work the way they intend? Will something have a savings or a cost? And we try very hard to do that. Evaluating the policy implications, of course, that's your job, and we don't step on your toes in that regard. Now, in terms of your specific question, we do try to estimate the impact of the Affordable Care Act on total national health expenditures, taking all the factors you mentioned into account, either directly or implicitly.
How long have you been doing this?
Today, it seems like quite a while, sir.
I know the feeling.
No, I don't mean to be a wise guy. I've been working as an actuary for 38 years now, 16 years as chief actuary of CMS.
And how many of those years have you advised the federal government?
Oh, all of them.
And I assume if indeed you deviated in terms of being political, you would never have survived all of these different administrations for 38 years.
If anybody thought I was taking a political role or allowing political beliefs or preferences to affect my work and my office's work, my own staff would be the first ones to throw me out of the office.
And I think my recollection is correct that you've taken on quite a few administrations in terms of what they wanted and what your reports indicated.
I'd like to think that we've offered sound, objective, technical advice to many administrations, some of the time for which it was appreciated.
Very wisely put. Could you evaluate what would happen in terms of health costs if indeed we were using a voucher system instead of the one that's outlined in this bill, and the health costs for the potential patient would be higher than the voucher, what would happen fiscally as it relates to overall health cost?
There is certainly a possibility that if the voucher payments don't increase fast enough, people might have very limited insurance options, very low value insurance, or perhaps no options at all. The hope, I believe, and I'm sure Representative Ryan could explain this better, is that it would change the underlying nature of healthcare cost increases. That's a worthy goal for everybody, but it involves risks that if you try to do it through a voucher program or you try to do it through lower and lower relative payments under Medicare for providers, that either the vouchers are inadequate or the payments are inadequate, and you can't buy what you would like to buy. That's a risk.
So the risk would not be just the Treasury in terms of costs, but it would be the potential patient. I mean, I think also I would like to ask, if they raise the age of Medicare in order to be eligible, what impact would that have fiscally? Well, you could, I would like to follow through on the chairman's suggestion that we send you questions, and I appreciate
Righty.
your service to this committee and to our country.
Thank you. Mr. Johnson's recognized.
Thank you, Mr. Chairman. Thanks for being here, Mr. Foster. The health care law cuts Medicare payments to hospitals by more than $150 billion, according to our estimates, and that estimate includes the impact of several provisions, the market basket reduction and the permanent loss of their annual productivity adjustment. MedPAC's latest data estimates inpatient hospitals will have Medicare margins of a negative 5% in 2009, and is it possible that some hospitals might be forced to cut back their staffs to survive the cuts and maybe reducing the quality of care provided to seniors and other patients?
That's a conceivable outcome. I would like to think that MedPAC and my office and others would continue to monitor the situation and advise you all. And if something like that happened, you would step in and say, we want to change the law to avoid that outcome.
Well, how would we change the law? I mean, we're cutting the amount that we're paying them, so what would you have to do, increase the pay?
Basically, yes, sir. If you passed a law that said I personally get paid, say, half of what I'm getting paid now, I'd probably quit. And if you came back and said, oh, okay, we'll pay you what you used to get, I'd probably come back.
Well, that's what's happening in our hospitals, at least in the Texas arena. You know, nurses, docs, and practitioners are laying off. They have to pay salaries and rent, and those are still going up, as you know. They'll be paid less than cost of goods. And do you think that's sustainable in the long term?
It is possible. If they can improve their productivity at much better rates than they ever have historically, which is perhaps not likely, or if they can get rid of the admittedly significant level of inefficiency that exists, if they can take other steps through innovations and joining in provider organizations, ACOs and so forth, then all of that is possible. Now, what I'm afraid of is it may not be probable.
Yeah, I agree with you totally, and thank you for your testimony, Mr. Chairman. I yield back.
Thank you. Mr. Brady's recognized.
Thank you, Chairman, and thank you, Mr. Foster, for joining us. I am concerned about the damage that will be done for our seniors as a result of this new health care law. Dr. Berwick wasn't able to answer a number of my questions on the impact, so I went to your report to get the answers, and I want to confirm them. I'm concerned that many seniors that get prescription drug benefits under Medicare will have higher Part D costs because of the flawed way in which the donut hole is supposedly closed. On page 13 of your report, you say, quote, providing additional coverage for prescription drugs dispensed in the coverage gap, the donut hole, will cause an increase in costs for the prescription drug plans and therefore an increase in the average Part D premium rate, unquote. In plain English, are you saying that prescription Part D premiums will increase for seniors who are not in the donut hole?
They would increase for all Part D enrollees who pay premiums. In other words,
including those who are not in the donut hole?
their premiums would increase.
Right.
On average, not by very much. The amount is shown in the table on page 12. Now, for people who make it to the coverage gap, or where the coverage gap
No,
would
that,
have been.
that I understand. I have some
Right.
more questions.
Okay.
One of the second point you make on Medicare Advantage, the new provisions will reduce Medicare Advantage rebates to plans and thereby result in less generous benefit packages, an estimated $1,500 a year over time. In plain English, is that saying that seniors within Medicare Advantage will have less benefits under the new health care bill?
Yes, sir.
On the same page, quote, the reduction in Medicare Advantage rebates will cause a large increase in the out-of-pocket costs incurred by Medicare Advantage enrollees, estimated $873 more a year over time. In plain English, does that mean seniors in Medicare Advantage will have to pay more as a result of this new health care law?
If the Medicare Advantage plan benefit package, in other words, the supplemental benefit package, stays the same,
They'll have to make up the difference out
yes,
of their pocket.
the enrollees would have to make up the difference.
That's my fear. Final point, there is a concern that the way this new health care plan was structured, it punishes seniors who are getting their retirement plan through their business that they retired from versus those perhaps of state, federal government workers. Removing the tax deductibility of their assistance for their medicines is going to have an impact. You say here that you have, quote, the anticipated movement of many of the Medicare beneficiaries currently enrolled through the retiree drug subsidy program to Part D plans. Does that mean that you anticipate seniors who are currently getting medicine help through their retirement plan from their business will be either forced or will move to the Medicare plan as a result of the cut in their help under this health care plan?
Yes, sir. And as a result of the change in the tax status of the subsidy payments to employers.
They left in place that subsidy help in its entirety for those government workers on retirement plans. Do you anticipate government workers being forced off or leaving their plan for Medicare?
Oh, I don't have any idea. I think it's a somewhat different issue.
Well, it is the impact of removing the subsidy. When it was put in place, they were equal. Workers in a government retirement plan and workers in a business retirement plan were treated equally. That parity is now gone with the removal of the tax deductibility. That was done to make them whole. So you don't, at this point, you didn't at least estimate that unlike private sector workers, government workers will not be leaving their plan?
No, again, it's a little bit different, sir. For the retiree drug subsidy within Medicare, you had an employer who was paying the drug cost for drug insurance for his or her retired workers. The employer could deduct that full amount.
Yeah, we know how it works.
And the Medicare payment through the retiree drug subsidy to the employer was not counted as income and did not reduce the amount that the employer could deduct.
At some point, we need to continue this discussion because I really think there are direct correlation there. So thank you, Mr. Chairman.
Thank you. The gentleman's time has expired. Mr. Starks recognized.
Thank you, Mr. Chairman. Thank you for having this hearing, and welcome back, Mr. Foster. In Medicare Advantage, under the ACA, would Medicare benefits be reduced?
The traditional Medicare benefit package would not be affected. The extra benefits that most plans offer would definitely be reduced over time.
Come back to that. The ACA extends solvency by about 12 years, correct?
Yes, sir, based on a 2010 trustees report baseline.
And ACA lowers cost sharing under Part B, saving beneficiaries there at the doctor's office, is that correct?
Yes, sir, for fee-for-service beneficiaries.
And it reduces out-of-pocket spending for prescription drugs, does it not?
Yes, sir, by closing the coverage gap.
Okay. And the ACA leaves Part B premiums, which are presently made up of Social Security deductions, the same, is that correct?
It would actually, for fee-for-service beneficiaries, actually all beneficiaries, it would lower the Part B premiums.
And would repeal raise costs for beneficiaries and reduce solvency?
It would essentially do the opposite of everything that the ACA did. In other words, putting it back where it had been.
Can I go back just very quickly to the Medicare Advantage benefits? It's always been a concern of mine that the benefits offered in Medicare Advantage are far different from those that are actually used. In other words, a Medicare Advantage plan may offer trips to China and all kinds of things that the members of the Medicare Advantage plan would have no possible chance to use. Do you have any figures that relate to the benefits, quote, offered as opposed to those that are actually used?
Directly, no. Indirectly, yes. In other words, when a plan submits a bid for Medicare Advantage, and they have to specify the per member per month cost of the various supplemental coverages that they offer, they have to justify that cost based on the past experience of the cost for those provisions.
How much they actually paid out?
Yes. So you can't have too much of a difference there without our challenging it and asking for a justification for the difference.
So it would be difficult for those plans to offer spurious benefits that are just there in name only, but aren't really very attractive to the members. Is that fair?
Well, I'm sure it happens to some degree in some cases, the gym club memberships, perhaps, that kind of thing.
Yeah, for me, they don't do me much good. Okay. Thank you very much. Thank you, Mr. Chairman.
Thank you. Mr. Teaberry is recognized.
Thank you, Mr. Chairman. Thank you for being here, sir. Medicare Advantage is voluntary, right, sir?
Yes, sir.
So you can sign up or you can drop off
That's right.
as a senior. Every senior I've talked to who's on Medicare Advantage said that they like the Medicare Advantage plan they're on because it offers them a comprehensive health care package, whereas Medicare fee-for-service does not. Do you know off the top of your head what percentage of seniors who are on Medicare, traditional Medicare fee-for-service, are in another additional plan, whether it be Medicaid, Medigap, retiree coverage?
It's a fairly high percentage.
Like maybe 90?
Probably not quite that high, but 75 perhaps. I can look those up for you.
I would love that number. Thank you, sir. So, is it fair to say that under the current system, Medicare fee-for-service is not meeting the needs of most seniors because they're choosing other forms of coverage?
I'd put it slightly differently.
Okay.
I'd agree generally, but I'd put it slightly differently. The Medicare benefit package, the fee-for-service package, is not exceptionally generous.
Okay.
It has significant cost-sharing requirements, and it doesn't have catastrophic coverage protection. So most Medicare beneficiaries who are able to seek additional coverage, either through Medigap, or they have it through their employer plans, or if you're low income, you have it through Medicaid, in order to avoid the risk of financial catastrophe.
And most Medicare Advantage beneficiaries do not seek that additional coverage, correct?
Generally not. Many plans have catastrophic coverage, but not all.
So if you reduce the number of enrollees that are in Medicare Advantage and they go in Medicare fee-for-service, then they will have an additional out-of-pocket expense, potentially a new Medigap coverage, for instance, that they'd have to pay for.
Typically.
Do you know who the largest Medigap provider is in America?
United Healthcare,
Is it affiliated with any other organization?
like AARP.
Are they the largest?
I don't know. But I
Could
would
you get
guess-
that information? Could CMS provide that, you think?
We can try and find out.
I would love, that would be great. So, is it safe then to say that if you are in a position to gain market share, you'd be opposed to the Medicare Advantage program to continue to exist? If you were a provider of an additional product?
I'm sorry, I didn't quite understand. Could you?
If you were in the business of providing coverage for seniors, and you are providing that holistic coverage as an addition to Medicare fee-for-service, the more Medicare fee-for-service beneficiaries there are, the better it is potentially for you to supplement your business by offering more coverage to supplement Medicare fee-for-service, meaning if there are fewer Medicare Advantage beneficiaries, they have to go back into Medicare fee-for-service, so you would be potentially benefited.
Yes, you'd have a broader market opportunity.
Because the odds are that if you no longer are on Medicare Advantage, you would need something other than just Medicare fee-for-service based upon what we already know, right?
Yes, sir.
So is it fair to say that what Mr. Ryan is trying to do, what he's been criticized for trying to do, doesn't acknowledge the fact that most Medicare, a majority, you said 75%, look forward to the number, but most Medicare fee-for-service individuals today don't believe that they have enough coverage, therefore are either supplementing their coverage, so it's not fair, because we're not that, to be critical, we're not comparing apples to apples. Is that fair?
Well, fee-for-service Medicare by itself is a basic package without catastrophic protection or some other features.
And what Mr. Ryan is also providing is a basic package that is for the senior.
That's correct.
Thank you. Appreciate that. Yield back.
Thank you. Mr. Davis is recognized.
Thank you, Mr. Chairman. Mr. Foster, I appreciate the work that you've done to try to make sense of the health care law and the impact it will have on seniors' coverage under Medicare. You have an important job. I thank you for your service. Surviving 38 years in the mosh pit of politics is a credit to a Job-like stability of mind to be able to keep focused.
Or limited mental faculties.
I think that's over in the United States Senate, probably where we'd find that. But earlier this morning, many of us asked Dr. Berwick his thoughts about the numbers that your office has put out. I come from a operations and planning background where the metrics are everything, and the assumptions behind the metrics are really how you can formulate effective policy decisions, make business decisions, and have some adequate degree of predictability about the way trends are going. I understand that there's no actuarial formula that's perfect unless you had the ability to see into the future, and I'm sure you would not be working here if that were the case. You'd have clients in other places. But the projections are hypothetical, but they're very critical to understand how these assumptions would play out for policy. And I think that I felt rather uncomfortable this morning asking specific questions that are based on data, not getting an answer. But I was wondering, technically speaking, if you could take a moment to explain for us the role of your office and how you do what you do. If you could give us kind of a soundbite version of that, outside of it being perceived by many non-numerically oriented folks as kind of a black art to come up with things that can get batted around. Really, I'd like to hear your perspective on how you come to your conclusions.
Sure. There are many techniques for estimation, cost projection that actuaries use, both in government and in the private sector. The better the data, the better job we can do. It's hard, of course, when you have something new, not tried before, where it's hard to predict people's behavioral response, people, employers, whatever. We have a staff of about 90 people in the Office of the Actuary at CMS. They're all sharp, above average, handsome, and beautiful, respectively. And they work very hard to try to estimate the financial and other impacts of any proposal that is asked of us.
Well, following on that, the Nonpartisan Congressional Budget Office has made clear that Medicare savings, as a result of the health care law, can't be counted twice. First, to shore up solvency of the Medicare program while also paying for a new health care entitlement program. Further, your office's April 22nd, 2010 report on the effects of the Democrats' health care law and the Medicare trust funds pointed out, and I'm quoting, in practice, the improved Part A financing cannot be simultaneously used to finance other federal outlays, such as the coverage expansions under the PPACA, and to extend the trust fund despite the appearance of this result from respective accounting conventions. I was wondering if you could tell us about this double counting issue, maybe elaborate for us a little bit.
I'd be glad to. It's nothing new, but it is relevant and important. I'll go back to the example that I used a bit ago, where suppose under the Affordable Care Act, a given worker has to pay $100 higher hospital insurance payroll tax. So that $100, that's the true cash, the $100 is sent to the Treasury. The Treasury credits the hospital insurance trust fund with a $100 Treasury security. And then the money goes into the general fund, and from there it's spent pretty much immediately, whether it's to offset the cost of the coverage expansions under the Affordable Care Act or for SSI benefits or anything else. But the money is spent. Now, later on, a couple of years down the road, we need our $100. So we cash in our Treasury security. We get the $100 back with some interest. Obviously, it's not the same $100. That money's already spent. We need to spend $100. So Treasury has to come up with $100, say by borrowing that much, to then give to us. So the original $100 can't both spend $100 over here for coverage expansions and $100 over here for HI. On the other hand, because of the way the trust funds are set up, we do get the help when we need it in the future. I don't know if that helps or not.
No, that helps very much. I think a few of my colleagues' assumptions on the other side of the aisle remind me of a production manager once who quipped that they were losing money on every product, but they'd make it up on volume. And we certainly want to avoid that. Thank you very much for your service. I yield back.
Thank you. Mr. McDermott's recognized.
Thank you, Mr. Chairman. It's good to see you, Mr. Foster. We haven't seen you for a while. You've been around as long as I've been here, so I gotten to see you on a number of occasions, and I liked what you said earlier. You like to know how it actually works. And as I look at Medicare, Medicare's administrative cost is 3%. That's the generally accepted figure. Do you accept that figure?
The way it's normally calculated is actually quite a bit lower. If you look at all the federal and related administrative costs for Medicare, it represents about 1.3% of total expenditures.
1.3%.
Yes, sir.
Now, insurance companies' administrative costs are estimated on an average about 14%, sometimes as high as 40% in the individual market. Is that correct?
Yes, sir. That's in the ballpark, depending on the nature of the insurance.
So if Mr. Ryan and the Republicans succeed in moving to a voucher system, that is, we hand $5,700 or $6,300 or whatever amount to seniors every month, how will that administrative cost on the insurance company side, will that be an added cost on top of what they're getting already? I mean, I don't understand where that administrative cost goes.
Well, any insurance premium that you see, just about any, will normally include amounts to cover the medical expenses and also the administrative costs and whatever profit margin is built in. So under Mr. Ryan's plan, a voucher payment would help a beneficiary purchase some level of coverage that would include the cost of administering the program.
And when you look at it from the two standpoints of the government and the senior citizen, the government costs would go down if we had a voucher system. Is that correct?
Yes, sir.
And what would happen to the cost to the senior citizen above the voucher? Would that pay for their cost, do you think?
It would depend on how the voucher amount is escalated each year. If it grows at a slower rate than healthcare costs.
That's what Mr. Ryan is talking about, less than the medical inflation rate.
In his original proposal, that's correct. I believe in his modified version with Dr. Alice Rivlin, it would grow at a faster rate. But if you assume that the voucher payment increases more slowly than healthcare costs, then over time, people would initially have to buy less comprehensive coverage. Now, that might help them purchase health care more prudently because they have more of a direct financial stake in it.
I mean, as they're getting older, they would be buying less health care coverage. Is that what you're saying?
Yes, whether it's an individual who's getting older or a new person who comes along and qualifies for Medicare, they might buy a catastrophic coverage instead of a more comprehensive one. What I'm saying is that can feed back into how much they spend.
Does that make sense, that as you get older, you need less health care coverage?
No, of course, obviously, as people age, they typically run into higher health care costs. The issue here would be how is the voucher handled? Is it adjusted for age? Is it one amount for all, and the insurance companies have to provide guaranteed issue regardless of age? Those are details to be worked out.
So it would be, you'd have to have some kind of regulatory system to make sure that insurance companies would sell a policy to an 85-year-old who had had several cancers.
Yes, I think that would be required.
I mean, you couldn't get away without regulation. You'd need the federal government involved in it.
I would tend to think so. In fact, I think Mr. Ryan's plan has that sort of thing involved. But as I said before, it's been a couple of years since I've looked at it.
Would his be called a government takeover of health care?
You'd probably have to ask him that question, sir.
Do you see any way that you can make the system that we put in last year in law better?
Sure.
Give me a couple suggestions.
Okay. If you think about Medicaid for a minute, the expansion of Medicaid eligibility applies to people under 65. So picture somebody who's 63 or 64 and qualifies for the Medicaid coverage. They turn 65, and of course they qualify for Medicare, and they then would no longer qualify for Medicaid. So that's, I hate to use the word notch for reasons you will remember, but I think that would represent a notch in benefit coverage. So that's a limitation that I think would need to be addressed. Let me give you one other example, if I may.
Your time has expired. If you want to complete that in writing, that'd be certainly welcome. Mr. Reichert is recognized.
Thank you, Mr. Chairman. Welcome, and I'm pleased
Use the word notch.
to hear your answers to the questions that my colleague, Mr. McDermott, asked. I asked a similar question of the previous witness and didn't get an answer as to what he might change or improve in the health care law, so thank you for those answers. I want to sort of stick to the theme that I was with earlier this morning, and that's this: if you like your health care plan, you can keep it, and specifically for seniors. So as I understand the health care current law, there are substantial cuts to Medicare in the area of $200 billion. And according to your figures, that by 2017, you're predicting that maybe 50% of the seniors who would otherwise enroll in Medicare will probably not enroll in Medicare. Is that an accurate statement?
Yes, sir. We've estimated that about 50% of the people who would have been enrolled in Medicare Advantage plans would no longer be enrolled under the Affordable Care Act. A slightly better updated estimate is closer to 40%.
So if that happens, would it be fair to assume that there could be a large reduction in this large reduction in enrollment, there could be fewer choices in plans offered?
Yes, we've not modeled the number of plans that would be offered, but the private plans like to offer a certain kind of benefit package consistent with HMOs or PPO practice. If they can no longer offer that package because of the reduced Medicare rebates that are payable, then they might choose to exit the market.
So those seniors that are in those plans, because of the reduction of the choices that might be made available, would no longer be able to keep the health care plan that they like?
I anticipate that's what will happen. I might add that that is not going to happen in 2011.
Right.
It's going to happen gradually between 2012 and 2017.
Right. So while your report doesn't speak to the contraction of plans, could you give me your opinion on which plans would most likely survive in that sort of scenario?
We anticipate that it would vary geographically. The payment rates will be directly tied to Medicare fee-for-service costs in the area in question. In some parts of the country, fee-for-service expenditures are very, very high. South Florida comes to mind, obviously. In areas like that, the Medicare Advantage plans can comfortably have a cost under the fee-for-service level, and they should be able to continue and do pretty well.
So would it be fair to say, too, that plans with a larger market share might be those that survive?
I'd have to think about that. They get an economy of scale, so that would probably help. But that's not the biggest factor, I don't think.
So what about the Medigap insurance? Would that be one of those you think that would still be around as plans are reduced through Medicare Advantage cuts?
Yes, there's a distinction. The Medicare Advantage plans have different payment rules, and they're governed by Medicare. The Medigap plans are overseen by the states, but that's a voluntary program that individuals decide to do on their own or not. It's unrelated to Medicare Advantage.
Right. But as Medicare Advantage plans go away, seniors are going to have to make a choice to go someplace, as Mr. Nunez said, or Mr. Tieberry said. They're going to have to go somewhere. Medigap would be one of those. I just find it interesting that, I don't know if you're aware or not, but Mr. Herger and I have been investigating AARP's strong financials, public support of this health care bill, and their interest in the Medigap insurance plans. And as Medicare Advantage disappears, Medigap Insurance United, for example, stand to gain a lot, in my opinion. Would you agree with that statement?
Well, I think that if our projection ends up being correct, as I have every reason to expect, and something like 6 to 7 million people, beneficiaries, leave Medicare Advantage plans, many of them, perhaps most of them, will want auxiliary coverage, and Medigap will be the most straightforward way to get it.
Okay. I yield back, Mr. Chairman. Thank you.
Thank you. Dr. Bastani is recognized.
Thank you, Mr. Chairman. And Mr. Foster, thank you for appearing before the committee today. Mr. Foster, it's my understanding that the insurance experts, many insurance experts outside of government, all conclude that the long-term care program in this law, the so-called Class Act, is likely to suffer from severe adverse selection. And the program will primarily appeal to less healthy enrollees, and this will drive up premiums. This month, a report by the Center for Retirement Research concluded that without adjustments, adverse selection will create a death spiral of rising premiums and declining participation. It noted that even with regulatory changes by the administration, premiums may never reach an affordable level for middle-class households. So considering your prior warnings, written warnings to Congress in April of 2010, do you agree with the conclusion that class as structured by the new health law is likely to suffer from severe adverse selection and a death spiral of unaffordable premiums?
I certainly agree that, as written, the class program would be subject to very severe adverse selection, which could cause the so-called death spiral or assessment spiral. It may be possible administratively to adjust the program enough to make it viable, and I know people are working to that end.
But if indeed these premiums were to go up, clearly folks on Medicare who have looked for some way to provide for their long-term care needs will suffer. Is that true?
Well, the class program, I think, was designed to try and meet two different sets of needs. One is as a form of federal long-term care insurance for younger people who over a long period of time would participate and then qualify for benefits.
Right, but the Medicare program today doesn't cover long-term care, so
No, sir,
it's
it
really targeted for that population.
Well, in
with
theory,
prior planning, obviously.
well, the other thing it tried to accomplish was for people who were in not so good health or who were older, to give them an opportunity to acquire long-term care insurance.
So you have real concerns about the solvency of this program as it's constructed today?
Yes, sir, I do.
Thank you. I want to change tracks now and just pursue a line of questioning I had with the previous witness with regard to physician shortages and the linkage, the reimbursement linkage that's there. And in your testimony, you describe unless providers could reduce their cost per service correspondingly through productivity improvements or other steps, they would eventually become unwilling or unable to treat Medicare beneficiaries. And that's because of declining reimbursements that are built in to the system. Is that correct?
Yes, sir, for affected providers like hospitals and skilled nursing facilities, et cetera.
Right. And so if that's the case, that's clearly going to hurt access for Medicare patients and most likely be very acute in rural areas where there's obviously less opportunity for these institutions in rural communities to make appropriate adjustments.
Yes, sir. If over some period of time the reimbursement rates become inadequate and you don't do anything about it, then I think access would be a significant issue.
Right. And we heard some platitudes about innovations in reimbursement, but no specific detail. And further down in your testimony, you talk about some of these payment system reforms and delivery system reforms facilitated through the research programs that are described in the bill. But you say that these outcomes are far from certain, and many experts doubt the feasibility of such sustained improvements and anticipate that over time, Medicare price constraints would become unworkable and that Congress would likely override them much as they have done to prevent reductions in physician payment rates otherwise required by the sustainable growth rate formula in current law. So I take that to mean that Congress will make adjustments to prevent these kinds of draconian cuts, which were built into the original assumptions on cost savings for the bill, and so we won't achieve some of those cost savings, and in fact, we're perpetuating the same problem. Is that a fair statement?
Yes, that's a reasonable summary of my concern.
Thank you. I sense that you don't have a lot of confidence in these prospective delivery system and reimbursement reforms that are being talked about. I mean, we've created a bureaucratic entity, but we don't really know what's going to materialize there.
I have a lot of optimism, but it remains to be seen whether it can be fulfilled.
Thank you. Thank you, Mr. Chairman.
Thank you very much, Mr. Johnson. Thank you, Dr. Foster, Mr. Foster.
Mr. Foster, Dr. Foster is my father.
Okay, well, thank you, Mr. Foster. Thank you very much for being here. Thank you for your service for many, many years. Let me just ask you, Mr. Foster, is it true that for the first 2 decades, all of the plan paid by 95%?
You're asking whether the Medicare Advantage plans started off being paid 95% of a traditional level of cost?
Yes.
Yes, sir, that's correct.
Prior to health reform, did Medicare overpay Medicare Advantage plans?
Subsequent to the Medicare Modernization Act, the benchmarks for payments to private plans and the payment levels were clearly such that for a given beneficiary, Medicare tended to pay roughly 12 to 15% more than if that person had been in fee-for-service.
What percentage of beneficiaries are enrolled in private plans?
Currently, it's about 27%.
Let me ask you another question. Do fee-for-service beneficiaries pay higher Part B premium to cover these overpayment?
Yes, sir. The fact that the Medicare Advantage enrollees to date have a higher per-person cost for Medicare, that higher cost feeds through to Part B and affects the Part B premium, which is paid by all Part B enrollees. Now, that difference will shrink over time under the Affordable Care Act.
Many of my colleagues keep asserting that benefits will be reduced, but I want to clarify there will not be a reduction of Medicare benefits even for those in private plans. Is that right? Am I right?
Not in this case, sir. For the people who are in the private plans, they will actually see an outright reduction in their total.
But with those in Medicare Advantage? Medicare benefits.
If you're referring to the traditional Medicare.
No, the guarantee benefits.
Yes, there's no change in those other than to expand them a little bit.
Well, thank you very much.
Thank you. Mr. Paulson, do you wish to?
Thank you, Mr. Chairman. I would like to ask maybe one or two questions. Thank you, Mr. Foster. I was just going to ask, your perspective. The health care law includes now multiple potential Medicare payment reductions for all health care providers. And in addition, there will be significant pressure and requirements to improve quality outcomes at the same time, at the same or reduced costs. So layering on top of that now, we have this new medical device tax in the new law that will make the tools these providers need to achieve their quality outcomes much more expensive, because that tax is likely going to be passed on to healthcare providers and consumers as well. Do you see how the medical device tax is in conflict or direct conflict with the goals to improve patient care and reduce costs within our healthcare system?
The tax on the medical devices, I agree with your assessment that that tax is likely to be passed on through a higher price for the devices, which would, other things being equal, raise healthcare expenditures.
Okay, and thank you, Mr. Chair. Maybe I'll follow up with one other question. I think one of the elements of the Accountable Care Organization oversight model that's included as a part of this shared savings. This means if an ACO, as it's known, succeeds in reducing costs by a certain amount and also meets selected quality measures, the hospitals and the physicians that are in the ACO will each receive a share of the savings that were generated. So this type of arrangement in which providers essentially have a financial interest to reduce care has been part of the several gain-sharing demonstration programs that are currently underway. Independent monitoring of each ACO or shared savings program site must be an essential part of the ACO program to ensure that these new financial incentives are appropriate and do not induce providers to limit a patient's treatment options and negatively affect quality of care. Would you support, or can you comment regarding independent monitoring of ACOs, just independent monitoring of these ACO, Accountable Care Organizations?
Well, I think what I'd say is obviously you do have to monitor the quality. That's part of the program, that you don't want providers to stint on care or avoid services that are really necessary. If they can avoid unnecessary services, that's great for everybody. But you do have to make sure, because of the financial incentive, that it doesn't go too far.
Thank you, Mr. Foster. Mr. Chairman, I yield back.
Thank you. Mr. Berg, do you care to question?
Mr. Foster, your office authorized an appendix to the Medicare trustees' 2010 report, which you questioned the trustees' projections that Medicare Part A solvency would be extended. And you stating that their estimates do not represent the best estimate of actual future Medicare expenditures. And I understand your office does not typically issue an ancillary report to the annual Medicare trustees report, giving an alternative, projection. What were the key concerns that you had with the trustees report that compelled you to issue this ancillary report?
Well, there's two factors here, sir. One is by law, I'm required to certify that the assumptions and methods used in the trustees report are reasonable. And in my comment in that certification, I said that the current law projection is probably not a reasonable projection, given that the current law itself may not be viable. Some of the provisions in it may not be viable. Now, in addition to that, we issued an auxiliary memorandum with the illustrative alternative projection that showed, under a different version of the law, if the parts that we worried about the viability, the physician payments and the productivity adjustments, if those are assumed to go away, to be overridden, then what would the cost look like? Now, we had done that in the past just for the physician SGR issue, and the trustees have asked us to do this. So I wouldn't say I'm at major odds with the trustees in any respect. We all recognize the concerns and want to make sure the public understands and you understand the concerns.
One additional question. As you know, the health care law cuts Medicare Advantage by $206 billion, according to the CBO. Can you elaborate on how these cuts will impact enrollee benefits and premiums and plan availability?
Under the current law, if a plan's cost is lower than the so-called benchmark level, then the difference, a portion of the difference, and to date has been 75%, is paid to the plans in the form of a rebate. And they have to use the rebate amounts to either reduce cost-sharing requirements or add extra benefits like dental or vision coverage or reduce Part B or Part D premiums. Now, under the Affordable Care Act, the standard for the rebates, the benchmarks, will be reduced significantly. And the percentage, what used to be 75% of this difference, benchmark versus bid, that will be reduced to 50%, although it can be increased for quality bonuses. But the bottom line is the rebate amounts are going to be reduced substantially. And in the written testimony, we estimate about $1,500 on average by 2019. So that will cut back to the tune of $1,500 on the extra benefits that can be offered. Now, the MA beneficiaries will also benefit from the fee-for-service effects. They'll have to pay a lower Part B premium and other changes. So they gain from that, but not as much as they lose from the lower benchmarks.
Okay, thank you. I'll yield back my time.
Thank you. Mr. Levin, do you have one more comment?
Well, just as a follow-up to that last question about Medicare Advantage programs, Mr. Foster, I think if your testimony is taken as a whole and not taken apart just for some advantage, talking about Medicare Advantage, it's clear that essentially a lot of Medicare beneficiaries were subsidizing extra benefits for others. And that subsidization essentially led to an advantage for Medicare Advantage plans. And now that advantage is being reduced. And as a result, a large number, the larger percentage of people covered by Medicare won't be subsidizing advantages for others. As that advantage is reduced, I think you would agree that there are other ways for the carriers to make up the difference. they can become more efficient, no? The insurance carrier can become more efficient.
Yes, sir, there's potential for that.
Indeed, I think there's a recent report from one of them that have reduced premiums because of the more efficient way that care is being delivered. And one can very readily argue that the reduction in that subsidy will lead to more carefully and effectively delivered health care.
At the margin, I think you're probably correct. In the big picture, I don't think that's enough to counteract the changes in the benchmarks. Now, I might add, because I don't want anybody to misunderstand me, I have no position on the policy issue of whether it makes sense or does not make sense for one group of Medicare beneficiaries to get an advantage and another group not to get it. That is a policy issue. That has been the case where the Medicare Advantage enrollees benefit from the nature of the design of the formula for payment. And that's been very valuable and has been very popular. To the extent that the Affordable Care Act removes most of that advantage, is that good policy? That's for you all to decide.
Yeah, but I think you described it accurately. A lot paid for an advantage for a minority. And we are now reducing that advantage and hopefully reducing a subsidy paid for by the majority can lead to more effective delivery of care. Thank you very much.
Thank you, Mr. Levin, and I want to thank you, Mr. Foster. I appreciate your lengthy stay with us this morning, and I would ask that if any members want to submit questions, that you would be allowed to provide written responses for the record, if you would, and with that, this hearing is adjourned.